So I'm going to introduce the next speaker, my good friend and my classmate from Cornell Medical College, well-known cardiologist from Seattle, Dr. Mahesh Mulumudi. He's an inventor, he's an interventional cardiologist, and he's a thought leader in the field of cardiology with academic and patent publications to his credit. He's president and CEO of Strato Scientific. He's also co-founder of the Strato Scientific. He did his medical school at Cornell Medical College, and he did his cardiology and interventional cardiology at Ochsner. And he's currently working as an interventional cardiologist at the Everett Clinic in Washington. Mahesh, go ahead. Mahesh is going to talk about the tower. How did we adapt in a pandemic? Go ahead, Mahesh.
Right. Thank you, Srini. Thank you so much. And thank you, Srinivas Kumar from India, too, for inviting me to present. And it's actually very nice to do this. Let me try if I can share the screen. And do you see my screen?
Yes.
Okay. So,
Mahesh, you want to go into the slideshow mode?
Slideshow mode, I will, yeah. Okay,
Perfect.
all right. Yeah, I kept the talk more as how we did towers during the pandemic time and how we have to adapt to the new atmosphere here because of the COVID-19 situation. So as we all know, the tower procedure itself is quite short and typically can be accomplished in about 45 minutes. It doesn't take more than 40 or 45 minutes to do a tower procedure, and patient will be done and out of the cath lab or the OR in about 40 minutes. But the patient's journey itself to have this tower valve placed and to be discharged home is quite complex, and they go through multiple steps to go through the tower procedure. And just as a kind of a typical example of the journey that patient takes to go through the tower, they are identified by a referring cardiologist or a primary care physician in general. And they tend to get an echo to assess the severity of the valve itself. And the patient gets referred to the interventional slash structural cardiologist, like our group. And subsequently, they'll go through an angiogram to see if there are any addressable coronary lesions. And after that, they go through a CT scan of the chest and the abdomen for the valve sizing and the vascular access issues. And then the patient has to see a cardiac surgeon to see whether surgical valve replacement or a transcatheter valve replacement, which would be the best approach for this particular patient. And then we can all get together as a heart team to discuss the candidacy for TAVR or a SAVR, and pick the right kind of valve. It's going to be a balloon expandable valve or a self-expanding valve. And what would be the mode of access? Is it going to be a transfemoral access, or is it going to be carotid or subclavian slash axillary access? And the patient receives the TAVR valve, and typically they stay in the hospital for about 24 to 48 hours. And we were discharging patients in about 48 hours, and sometimes they go home the next day, and follow up with cardiology in 1 week and echo in 1 month. As you can see, it's quite a bit of steps, and most of these TAVR patients are elderly, and when they're going through these multiple steps to get this TAVR valve done, they go through quite a bit of coordination, and we do have TAVR coordinators to guide them through the process, but the COVID situation did not help matters, and it made it very difficult for us to achieve these steps. And the COVID-19 completely changed the landscape for us. The first COVID-19 case in the United States actually happened at our institution in Providence in Everett, Washington. And that was on January 21st, 2020. Within hardly about a couple of weeks, it became a public health emergency, and our hospital started getting flooded with COVID-19 patients. And in preparation for the increased healthcare demands at the hospital, and including the PPE shortages that we were experiencing at this time, and some of the PPE shortage was also being preemptive and trying to save the PPE for the patients that we need. and all elective procedures went on hold. And TAVR, majority of the times, is an elective procedure. Most of these patients come to the office and get scheduled for TAVR, and that's how, and they go through the steps like I just described. And during the pandemic, the situation was slightly different. These patients were not getting TAVRs for weeks at a time, and we were worried what would happen to these particular patients that are having severe aortic stenosis and symptomatic. Is it something that's going to affect us adversely, or especially the patients? And during the new landscape and elective procedures, as they were postponed, and more patients with severe aortic stenosis were increasingly being admitted to the hospital with acute CHF and syncope. And we were trying to conserve beds at the hospital for possible COVID surges and COVID patients. And hospitals were overwhelmed, and we could not keep the patients in the hospital too long. And they would come with a syncope, and then they have severe aortic stenosis, which we knew from the past, and they're waiting for a TAVR to be done. And we had no way but to kind of watch them and try to discharge them as quickly as we can. This was a difficult situation for us at the time. And in addition to that, typical TAVR patients are older, and they're more than 75. And usually they are accompanied by some family members that care for these patients, both in the hospital and outside the hospital. And that also became very difficult as we closed the hospital for visitors, and that became a huge issue. And as mundane as it may sound, all the conference rooms at the hospital were barred from use, and there are no conference rooms. So we cannot have the heart team meetings at all, and visitors cannot come. So all this put together changed the landscape for us in a very significant way. And we had to innovate, as everyone else did, and all over the world did, and we are no exception for this. So we kind of developed a few algorithms. This is one of the published algorithms for what to do with TAVR patients during COVID-19 era. And if they get admitted to the hospital with emergent cardiogenic shock or acute respiratory failure, we were doing more TAVRs in patients than we ever did before. TAVR as an inpatient is relatively very rare for us. And in any given year, we would do one or two procedures at the most. During 2020, we did 8 of them as emergent procedures. This is quite not the typical situation for us. And we also had to come up with criteria to decide and to prioritize which patient would get TAVR first compared to the ones that are stable and waiting. And one of the criteria that we used was using a Vmax of greater than 4.5 or a gradient greater than 50 millimeters across the aortic valve. We decided those patients need to be prioritized prior to the ones that are less severe aortic stenosis. And if they are kind of prioritized, we kind of put them in front of the line and try to clear up those TAVR procedures first. Patients with chronic angina, patients having chronic shortness of breath, and we typically postpone them anywhere from 4 to 12 weeks and to do the TAVR in these patients. This is both for conserving beds at the hospital to allow for TAVR patients to stay and then leave early enough so that COVID-19 patients have space, and that's what we did. And there was a big shift in post-TAVR patients from ICUs to regular telemetry beds. And COVID in general has done a lot of good things, and I'll try to point out a few things that it has done because of the changing landscape. So we had to steps to receive the TAVR itself. We modified it. The referring cardiologist started identifying and seeing patients on audio video call, telemedicine as we call it, and they need an echo to get the aortic valve, and which I highlighted in red. They need to come in for that. There's no remote echo at this time. And patients are evaluated by the interventional team. They were done an AV call and telemedicine calls, and coronary angiograms. Of course, they have to come in and have any PCI done. And we started combining CAT scan and coronary angiogram on the same day, even though the risk of diload exists. If the renal function was reasonable, we started doing both the procedures at the same time. And one of the things that we innovated during this time is we started emphasizing the the benefits of using as little contrast as possible. We should be doing it anyway all the time. For coronary angiogram, we even reduce the amount of contrast that we were utilizing. And some of the cases we have done the entire PCI of two vessels with about 80 cc's of contrast to conserve the contrast for a CT scan use on the same day. And the patients were evaluated by the cardiac surgeons, and that was done on AV call also. And the heart team met over Teams, and there was no more of these conference calls. So we met over Teams. The Microsoft Teams was our go-to meeting sessions. And a patient would receive the TAVR, and we started discharging patients on the same day. Patients that were healthy enough, we started doing same-day discharge for TAVRs. And they would follow up with cardiology on an AV call, and they would get an echo in about a month. As you can see, there are quite a few steps that we modified during the COVID time, both in terms of patient selection, in the terms of how they were assessed, and we started realizing the principles of reducing the contrast use, which we normally do, but even more stricter about the contrast use during coronary angiography, and getting CAT scan done on the same day. This improves the efficiency of how the patients move through the TAVR pipeline and get the TAVR valve done in a timely manner. And this is one of the biggest changes that happened to us during COVID. And the new normal became the audio video calls. That became the new normal thing, and including the cardiology, interventional cardiology, the cardiac surgeon. And the families would visit the patients in the hospital over iPads. And we had these rolling iPads in the hospital so the families can visit them. And there is no physical visitation. So we were doing the AV calls for them to visit their family members. And they would see the post TAVR visit in about a week on an AV call, and see the cardiologist in a month on an AV call, and the heart team met over Teams. And that's one of the things that we have done. And the COVID landscape is changing once again, and mask requirements have reduced quite a bit. And we are now having visitors to the hospital and the clinic, and patients visits resumed. And life is starting to look almost normal, and at least we think sometimes. But the Delta variants are again changing the landscape a little bit. With all this, the pandemic has definitely left a mark on the way we manage patients, and especially TAVR patients for us. Our TAVR pipeline for each patient to go through the entire steps and to have a TAVR valve done, the average time was about 8 to 12 weeks. It's actually quite long, and we were trying to shrink the pipeline for a long time. What COVID has done is that really brought the timeline down to 3 weeks now. And because of all the changes, because all the things we learned during COVID-19 situation has helped us a lot. And there are many changes that were instituted during the 2020 COVID time has helped us significantly. Patient visits for us for TAVR evaluation, besides actually doing the TAVR, doing the angiogram, doing the CAT scan and the echoes, everything are turned to AV calls and telemedicine calls. And thanks to CMS, and some of the reimbursement issues have been addressed. So it became a regular thing for us to use telemedicine to see these patients. And this also improves the access to the patients that are being referred from remote places. And Pacific Northwest is really beautiful. We live in a very nice hills and ocean type of a place, but there are a bunch of islands here that patients come to us from. And what it has done is, because all the teams got used to the telemedicine calls, their patient access also has improved significantly. We're able to see them on AV calls, and make their patient movements were minimized significantly, and they come and see us only when absolutely necessary. Our team continues to meet over Microsoft Teams. That's what we use. That made our life easier, and participation in these meetings have improved significantly. The number of people that participate on our teleconference and telecalls has significantly gone up, more than what it used to be when we used to meet in person. And looking to the future, patients will be seen remotely more and more. And I am really waiting for technologies to examine patients remotely, and they will arrive. That's my belief. As Srini was introducing me, I try to do things that are at least try to be innovative in a way to improve technologies to examine patients remotely. And telemedicine will eventually have the medicine beyond the tele part alone. And that's what I'm really hoping for. So I kept the talk such a way to really point out the practical aspects of what we did during COVID time with TAVR patients. I didn't go into the techniques of doing TAVR, and we all know that, and all of us here know how TAVR is done. So I just kept the talk in the direction of how we accommodate to the changing landscape of COVID-19. I will stop here and ask any questions you may have. Thank you.
Thank you, Mahesh, for that wonderful presentation. I know we had to be innovative in these new, difficult, and challenging times. And I think everybody is innovating in their own ways. I think, TAVR is no exception. I have just one question. Is there a role for valvuloplasty? Like, we used to do bridging valvuloplasty for these people instead of going directly to TAVR when there is really a sick patient comes into the ER rather than going directly to the TAVR.
TAVR, valvuloplasty has a reason, but if somebody needs an emergent valvuloplasty, and if they are a candidate for TAVR, we are doing TAVR at the same time, because the time it takes to do a TAVR and valvuloplasty is not that different, and even the complexity has gone down significantly. The other thing we are doing is, if a patient is in a cardiogenic shock and really sick, we have done the TAVR and placed an impella at the same time to support the patient and take care of them that way. So that had helped us quite a bit. So I don't know if a temporary valvuloplasty would be helpful. The only time is if they're not a candidate for TAVR. If we want to see how they respond to valvuloplasty, we have done valvuloplasty to see how they clinically respond and offer a TAVR in a 2 to 3 months time. We have done that.
Thank you, Mahesh, for that wonderful presentation.